तुम्ही म्हणजे सिमेंट फ्लोरल असं.
YouTube लाईव्ह येत नाही आहे का?
येतंय सर, येतंय.
Sir, we are live.
Good afternoon. At the outset, I am very thankful to our Ravi Ramakantan sir, very senior person in the field of radiology, and I thank at the outset to him. So he's sharing his knowledge to all of us, and we are blessed with such an huge personality in the field of radiology. He has very short CV. CV is a former professor and head of department of radiology, said GS Medical College and KM Hospital. At present, honorary consultant in radiology department, Kokilabin Hospital, Mumbai. Visiting consultant in radiology, GS Medical College and Hospital. Friends, the topic we chosen as a coordinator and moderator for us today is the pediatric X-ray chest. I think X-ray is one of the commonest radiological investigation which is ordered by a pediatrician, and I don't know how we interpret it. We're absolutely dependent on the radiologist with blessing with them the interpretation of having a clinical correlation with your patient. So friends, not taking much time between the beautiful academics and you, good afternoon all of you. I request our chief guest, Jain Joshi sir, to say a few words about today's session. Later on, Vinayak Patil will say a few words, and after that, Samir will take over. Thank you.
Good afternoon, everyone. And at the outset, let me thank Dr. Hemant Gangulia sir, Dr. Amol, Dr. Jay, and I may extend my wishes to all other colleagues who have joined. And it's really a privilege and pleasure to see Dr. Ravi once again. It was my great fortune that I could invite him to Pune on 2 or 3 occasions, especially to listen to his talks on the X-ray. And I must say that they were very enlightening. And it's really good to see him after a long time. And I'm eagerly waiting to hear from him once again. Dr. Ravi, most welcome. And it's a real pleasure to be having you around. Thank you so much.
Thank you.
Thank you. Dr. Vinayak, are you there?
Yeah,
Vinayak,
yes.
He's the Vice President of IIP,
yeah.
please.
Thank you. Thanks, Jay. Actually, X-ray reading is if an art, I think, which is known to very few, I think, because though we prescribe, as you told, that it is the most common investigation we prescribe, but I think very few of us know the art of reading X-ray, right from basics, which was taught to us in UG or PG days. But I think we have forgotten it. We just order X-rays and see just a few things, and many times miss many things. So to go to the basics, I think this is a nice way to have this talk by Dr. Ravi Ramakantan sir, and I hope this will be very helpful for all of us, like general pediatricians, to again go to the basics of X-ray. Thank you.
Thank you, Vinayak. Dr. Hemant, are you there? You're Maha President, please.
Thank you, Jay. Not taking a lot of time, but respected faculty, Dr. Ravi Ramakantan sir from KM. I have seen him from my student days when I was at KM hospital, taking the X-ray for his expert opinion. And my Vice President, Dr. Vinayak Patel, State Convener Jay Bhandarkar, and Dr. Jain Joshi, today's guest, as well as moderator Chief Samir, as well as all the attendees on the Zoom dais, as well as the Maha YouTube channel. Because almost we order X-ray chest while seeing the patient, and almost 60 to 70% times we have to read on our own, and more that on peripheral settings. And more often we find there's a subtle haze or some small pneumonitis, vague terms, and then this is to be correlated, and what viral and what bacterial and small things are there. And so they're all gray shades and black shades, and we have to distinguish between them. So we are very fortunate to have the eminent distinguished faculty to teach us all the things, and I think so this will be a class for us on X-ray chest pediatric exercises. Thank you very much.
Thank you, Dr. Hemant. Dr. Samir, are you there?
Yes, I am there.
Samir, sir, please
I
start.
will not take more than 2 minutes, but it's my duty to actually introduce sir. The most important line I feel probably with sir is, I believe that radiology is about patient's care and not just the interpretation of the images. So true, so important thing what he mentions in just one line. And it is so true. Why? Because it's a Ravi Ramakant sir, which is telling us from last, I am hearing him from last 22 years. In our Vadia days, we used to go to KM hospital, and we'll definitely never miss his lectures, particularly in the Thursdays and on Fridays. I used to go whenever on the Thursday or other Friday between 3 to 4 p.m. So patient is the center of the medical activity, what he used to tell us. And I personally feel that I feel so lucky today to have Ramakant sir here. And I got the same compliments when we explained and we told to the people and appeal for joining the YouTube channel and also on the Zoom meeting, and telling that Ravi Ramakant sir is taking the lecture for all of us. So Ravi Ramakant sir is a ex-HOD and alumni of the St. GS Medical College and KM Hospital, Mumbai, and currently the director of radiology department at Kokilaben Dhirubhai Ambani Hospital in Andheri, Mumbai. And over the years, I think probably most 35 to 40 years of his field in the radiology, he has created generations of excellent doctors. Besides being the god in radiology, he has done many genius work across all subspecialties. And I can no doubt to say that all the subspecialties were like in the pediatrics, what we know, the basic of those can be find out on X-rays. Can you believe on that? Yes, I believe in that because I have seen and I have find out that way, the way Ramakant sir has told us. So over to you, Ramakant sir. Now it's yours, so you can start your screen.
Okay.
Thanks.
Thank you. Good afternoon. And I see that I'm amongst friends here, a whole lot of new faces, old faces, new voices, getting a little older myself. much older. Let me start with my presentation and see what is going on here. I'm trying to share my screen. Okay. Okay, my screen is shared. All of you
Yes,
can
sir.
see.
Yes, sir. Yes, sir.
Okay, now this is perhaps one of the most important slides in this whole presentation. As many pediatricians have said before, there is a huge problem in radiology because nobody wants to do conventional radiology. And in adult radiology, you can get away by doing CT or MR when you do not know conventional radiology. And in that bargain, I think it's extremely tragic that radiologists forget that medicine is about patients and not about doctors. I like to do CT. I love CT. I am good at CT. Therefore, I will do CT. Not because it's good for the patient or it's bad for the patient. That being the unfortunate truth, we are at a stage where it is possible that those of us who are not really bothered about cause and radiation may switch over to doing CT for pediatric patients at a drop of the hat. That's not good. That's not good medicine. That is not good radiology. So it is a vicious cycle that I do not know how to read plain films. Therefore, I will do CT. In children, that will never work. That should never work. And therefore, you as pediatricians will be dependent for a long time to come on plain films to look at what's going on both in the acute and chronic setting. This is an extremely important preamble. Plain films are not going away for a very, very long time, even if you have ultra low dose CTs. Because plain films will be there for regular walk-in patients. Plain films will be there for bedside radiology. Plain films will be there for long-time follow-up. For all of these, both for acute and chronic and not so chronic illnesses, it will be plain film radiology as far as pediatrics are concerned. Now, there are 2 points in that. One is that you as pediatricians know what you are looking for. We as radiologists often do not know what we are looking for on a plain film unless there is excellent rapport between the pediatrician and the radiologist. We'll leave that for the time being to a different time in this lecture, but I will start with some issues that are extremely important as far as understanding how plain films look like and how to correct for these when you look at plain films. And this old saying that the carpenter has to know his tools is extremely important. You have multiple issues written in front of you. One of the most important is whether it's a supine film, that means the patient is recumbent, or an upright film. Except for older children and walk-in patients, most of the time, pediatric radiology is done with the patient supine on the table. That is a huge problem. HUGE, all capitals. Because how you look at images and pathologies on supine films is so much more difficult than when you have an upright view, which is not always possible, even in walking, talking patients, and of course not in bedside radiology. That really, really complicates interpretation of all radiology and try to explain how things are so very different when X-rays are done with the patient recumbent. So that is a huge issue. I mentioned rotation in front of it because especially in really small children, a neonate, for example, or an infant, for example, small amounts of rotation can make a big difference to what looks black and what looks like white on plain films, and how you compare the left and the right side when there is rotation. So these are the main issue. The one other issue is the third point is when do you do a lateral view? Now, the lateral view is a funny problem. People do not ask, pediatricians often do not ask for lateral views. I mean, that is out of the antenna. It's not in our field of imagination that we can do a lateral view. Therefore, few lateral views are done. Therefore, our expertise in looking at lateral views is bad. Therefore, we don't ask for lateral views. As far as pediatrics are concerned, pediatric radiology is concerned, especially in our country, lateral views are quite useful. I wouldn't say very, very useful, but they are useful, and I'll try to show some examples of how it can, in a moment, change the perception of pathology on the chest wall. The next, of course, is our follow-up X-ray, which is again, I must repeat, an important part. It's like blood pressure, temperature, abdominal GERD, TDS, chest X-ray, TDS. It can't open like that. There has to be some deep understanding of how often we should be doing chest X-rays in emergent patients in the ICU and those patients who have not so emergent case. For example, a routine pneumonia. For example, breathlessness. How often should we be repeating? The background of all this, doing more X-rays, is that radiation safety is something that we don't think of. I won't blame you because many radiologists don't think of. Is a real issue in pediatrics. We cannot say when it becomes unsafe. We cannot say how far it is safe, but every bit of radiation adds to the possibility of something going wrong as the child grows. So radiation is bad medicine. So you avoid it as much as possible. And that should be the watchword of all pediatricians because, for example, when you do bedside radiology, radiography in the ICU, you are the people, your nurses are the people who are going to be around when X-rays are being done. And your own safety is important. Of course, the small child safety is also important from the radiation point of view. Radiation hazards are real. They are not academic. They are not something for the West. It's for each one of us to take care that children are not used to unnecessary radiation when not required, just because we want to rule out or just because we want to do it for some other reason. So it's an important issue. And finally, I'll come down to ultrasound. I don't do practice ultrasound. I don't know how to do anything in ultrasound. But even for chest pathology, ultrasound is an extremely useful modality of picking up a whole lot of stuff. You attend ultrasound conferences, they will show images which will rival plain films. So be aware of all those situations where ultrasound can be used. It's of high resolution these days. It can be done by the bedside. It is dynamic and it is relatively cheap compared to CT scans. So if you are tuned to ultrasound in chest, you can avoid a whole lot of CT scans compared to what you would if you're not even aware that ultrasound can be used for chest radiology. So with that preamble, we will start with what's happened now. Why is my slide not moving? Yeah, okay, now it moves. Okay. So I start, I'll tell you what the course of my lectures is going to be. I will take you through the process of not missing findings on the chest film. Once you do that, 90% of the battle is won. To pick up a finding on a chest film is the hardest thing as far as plain film radiology is concerned. And telling normal from abnormal. And we talk of artificial intelligence and things in radiology, it's going to take a long time before artificial intelligence can equal human stupidity. That's a beautiful thing I keep hearing about artificial intelligence. And it says that human intelligence is no match for the stupidity of artificial intelligence. So AI, and that's a big word in radiology, is going to take a long time before it comes and looks at plain films. Therefore, human eyes will be important. And 4 pairs of eyes, 2 of yours, 2 of radiologists, are better than either of us. Just the radiologist looking well, or you looking at the plain films. So we start off with what to ignore, right? To know that this is normal, this is not normal. And the one that is always with us is the ubiquitous thymus gland. The thymus gland can be dangerous because it can look like so many other things. It can be very small, it can be very big, it can be very big today, and it can be very small 4 days later. It can do magic, it can do wonders. However, the best part is that it's extremely easy to pick out something as normal thymus. It's not at all difficult if you follow simple rules. The first rule is that no matter how big the thymus gland is, sometimes some of you must have seen it on thymus gland or on CT scan, it comes from the apex up to the dome of the diaphragm. It can be huge. No matter how big the thymus gland is, it does not shift stuff. It will not push the heart, it will not push the trachea, it will quietly be there creating trouble for everybody in interpretation. And that happens. I mean, this lecture is mainly for at a resident level, and I keep giving homework. Like a school teacher, I give a lot of homework. But now that we are not live face to face, giving homework is of no meaning because I'm not going to check tomorrow whether you have done the homework or not. The homework would be why. And Bachu Lok, I'm talking about Bachu Lok is the students in the audience. I mean, I refer to them all the time as Bachu Lok. It's nice to call them Bachu Lok. And when I'm talking to pediatric patients about pediatric patients, I say, no, not that Bachu Lok, the real Bachu Lok. So the Bachu Lok of pediatrics who are eager postgraduate students keep asking why for everything. When was the last time after joining medicine that you asked why? You stop asking why in 8th standard. Because after 8th standard, you get into the neat battlefield where asking why is not important at all. All that you need to know is 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, so on and so forth. It's not your fault. It's how we select students into medical care. So therefore, it's great fun to ask why. It's great fun to go beyond the science of medicine. And one time, and this is nice homework for all of you, adults and children in radiology, in pediatric specialty, is to read about something called the pale blue dot. This is how I talk lectures. Okay, people say, Ravi sir is taking radiology and he is talking about the pale blue dot. Okay, so I'm asking you this. Read about the pale blue dot. Pale blue dot. And write a 1-page essay on what thoughts it brings to your mind. Reading about the pale blue dot. And if you feel like you can email that to me, raviramakantan@gmail.com. I'm not going to mark you. I'm not making you pass or fail, but that sort of makes you think that there is a human side to medicine. I mean, you are facing the day in and day out, the suffering of one child, the suffering of the whole family, which is unique as far as medicine is concerned. You see it day in and day out. But sometimes it tends to get mechanical and you don't see that other big picture of William Osler's look at also the patient who has the disease, not just the disease that the patient has. So you can look up the pale blue dot and start off your radiology education, medical education with writing an essay. And somebody told me, one of the residents told me, sir, thank you very much for asking us to read about the pale blue dot, because for the first time after 8th standard, I'm writing one page of original thinking. That's useful for all of us. And all of you teachers there in the audience, keep thinking of something beyond radiology for your residents to work on, because beyond pediatric. Pediatrics will be there all your life, but there's something beyond that will bloom your way of looking at human suffering in pediatrics. So we come down to the thymic gland, and there I told you that it's extremely easy because thymus does not occupy space. And there are two specific signs which the thymus gland exhibits that have been described by a huge radiologist called Benjamin Felsen. Now, Felsen is the guru of all chest radiology in the world. And I will urge all radiology, all pediatrics teachers, you have to excuse me, I keep saying radiology all the time, that each of you in your departments should have a personal copy, I mean, in your department library, a copy of this book written by Benjamin Felsen, Fundamentals of Chest Röntgenology by Benjamin Felsen. And I would urge all pediatric residents to read it once over. That's it. You read that Bible of chest radiology, you are a master. It's a beautiful book. It's a simple book, a book full of humor. And that's all that you need to know to be able to interpret chest radiology. You don't need Ravi Ramakanth. And you can read that book in 2 flights between Bombay and Delhi or Bombay and whatever. It is a phenomenally easy book to read. Fundamentals of Chest Röntgenology by Benjamin Felsen. You can order it on Amazon or you can buy it from somewhere. If you order it on Amazon, I get some commission on that behalf. Anyway, so 2 signs in thymic gland. The one that is commonly talked about is the sail sign, because it is limited by the minor fissure. So you have to know this. It's called the sail sign because it looks like the sail. Why does it look like the sail? Why? All the time. And then medicine becomes easy. You don't have to mug up 100 things. You just have to use your thinking. Now remember, all residents here, you are extremely intelligent people. You have come through the neat battlefield. And when you have that intelligence, you can apply that intelligence to the practice of medicine, not just being good doctors, but you can apply by asking why. This is the sail sign is like the image on your right. I hope you can see the pointer. Sometimes the pointer is not seen. So you have this triangular shaped structure, the one that is limited by the minor fissure at the bottom, and the thymus gland, because it is soft, it's like a wet sponge. Thymus is all fat. And if you're in a medical school, you can go and attend autopsies and see even now how the thymus is small. And if you have a Bachu autopsy, you can see how the thymus gland is really, really soft and full of fat. And most of it looks yellow. So this is the sail sign. It is triangular like this. It's in that location, more often seen on the right than the left. On the left side, it's the arch of the aorta. It creates all sorts of problems. That's the sail sign. Most of you are aware of it. When seen, it's diagnostic of thymus, but unfortunately, it's not seen often. What is seen often is the thymic wave sign, W-A-V-E, wave sign. The margin of the thymus, you have to see, look at it carefully, looks like a crenated margin. It's like that, more often on the left than on the right. The sail sign is more often on the right than on the left. Now, the obvious question, why does it look like that, producing the wave sign? It's like waves on water. Now, if you look at that carefully, you'll find that the waves like that correspond to the anterior ends of the ribs. The thymus is an anterior structure. It's a soft structure, So when it goes against the costal cartilages, which you can't see on the plain film, it gets impressed by the costal cartilages. So what you don't see is the ghost of the cartilage, costal cartilage, and you see these wavy outlines. I hope you can appreciate that there are waves here all the way down, and this is the thymic wave sign. When seen, it's diagnostic, but it is again not often seen, but it is more often seen than the sail sign. People know the sail sign. Not many people know the wave sign, though the wave sign is more common. Therefore, you can pick up thymus easily on the chest film. Now, you're looking at some patient who has got a lower lobe pneumonia. Something is happening in the left lower lobe. You're hearing some unwanted sounds there. You see something like this. You may wonder what's going on if you don't know that this is the normal thymus. Then is an extremely important part of plain film radiology, being able to appreciate shades of gray. Now, when I explain to you, it may look like something fancy, but it's quite simple. That you must have seen on CT scans that fat looks black, pitch black, right? Hounsfield units in very low minus, so on and so forth. Therefore, on plain films, it should not look white because white is water, white is heart, white is liver, white is spleen, white is muscle. That looks like soft tissue. We call that all that soft tissue on the CT scan on plain film. Thymus has a whole lot of fat. Therefore, thymus is never as white as the heart. The heart is fluid or water, saline bag, whatever. If you are a radiology resident, I told you, get a saline bottle, get a little bit of paraffin from the biochemistry lab, keep them side by side and take an X-ray, and you will see that water is white and paraffin, liquid paraffin, oil, whatever, is black. Heart is white, thymus is gray. Now, if you are sitting in a properly lighted room, this is another thing. And this is fundamental to all Bachulok. Bachulok, do not look at X-rays against the tube light of the ward. Never, ever do that. It's wrong medicine, it's bad medicine. If this were the X-ray of your child, you would not do it. So there are two ways of looking at films now. You either look up on the monitor or you look them on the film. If you look at like that against the beautiful sky, you will miss more findings than when you look them up on the view box. Now, I know what you're going to say. I am taking a busy round on a post-emergency 40, but you look, what do you expect me to go to the view box every time? Because if you don't practice this, collect all X-rays together, look at them up when you're on call or whatever, look them up against the view box in not too lighted room. If you come into radiologist's room, you'll find the rooms are not well lit. They are dark. And we still make mistakes, right? It's like watching a movie. You like to be in a dark room. Now, as radiology is something like that. The darker the room in which you are, the closer to the view box that you are, the less the chance that you will miss finding. I'm not saying we don't miss finding. We miss a lot of finding. But you or anybody else who looks at a film as the way it is supposed to be looked, you should at least learn that this is the way to look at a film. And every time you don't do that, you should know that you are doing something wrong, which is not in the best interest of the patient. So if it's possible for you to look against the view box, don't ever look at it against the tube light or the patient's room or the ward. Because this difference in density, for example, you can see it very clearly here. You'll see the blackness of the lung here, and you see the whiteness of the heart here. And between this area, which is the left heart border, and the outer margin of this gradated margin, you can see something which is gray. It is gray because it is thymus. It is gray because it contains fat and therefore thymus. Therefore, beside the wave sign, it is a normal thymus gland. Because when thymic tumors come in in thymus, when there are thymic tumor, the tumor tissue replaces most of the fat, and most times big thymic tumors are solid, pushy lesions which lose their blackness. Now, there are many other instances in chest radiology where appreciating this grayness is very useful. Now, you think it's magic, it is rocket science, or it is a COVID science, or whatever. No, it is not. It's simple. Once you are aware that you can look at gray on chest films, you will be able to appreciate that. For example, if you have pneumonias produced by oil inhalation, okay? Because it's oil, that pneumonia in the child is gray. And I can tell you that more often than not, I have been right in picking up lipoid pneumonia introduced by inhalation of oil just because I look at this gray. I know I'm wrong. It's often, I'm wrong sometimes, but that's something I don't usually miss because I'm looking for gray pneumonia. And it looks like magic when I say, ask history of oil inhalation. That's one. There are tumors which contain a lot of fat. Hamartoma is one in the lung, for example. And there you can pick up the grayness of fat in those tumors. Leave the details alone. This is good medicine when you're able to appreciate, learn from your residency days that there can be something between soft tissue and air in the lung, and that is fat. So anytime you see on your CT scan, this is another thing you should do. I keep telling this to radiology residents. You have a bachu with a CT scan in front of you, put the CT scan here, look at the chest from here, and compare what looks like what. You can sit with your friend in radiology and compare, and that way you learn from CT scan back into chest bone, and that learning is invaluable. You become a master. I have seen it. It looks like this on CT scan. It looks like this on plain film. The next time I see it on plain film, I can imagine what it looks like on CT scan. All of this is hard work. I know that pediatric residents are stressed tremendously, especially on call days. You have no time to do anything at all. But when you can do it, this is the way to really learn plain film radiology. Go back from CT scan to plain film, and you can become a master in a few years. Meantime, understanding fundamentals of why something looks like what makes you remember that if you see something like this, the wave sign, the sail sign, the gray soft tissue, you know that it is fat, no matter where it is on the chest film. So this is what I wanted to tell you on this about thymus. Does not occupy space, does not push stuff, no matter how it is. If it is a normal thymus, and it has these two signs, the sail sign and also the wave sign. Let me move forward. Now, this is another thing that many of you will be aware of, right? Now, you look at the image on your left. The other thing I want but you look to see during the course of my lecture is the way my slides are projected. So how you make PowerPoint presentation. Now, when you are talking of radiology images, make the background black. I see all funny things about the backgrounds when many people, including radiologists, project slides, right? In radiology, the backgrounds have to be black. That's like no argument, no nothing, because so much research has been done that when the background is black, what you see is very different from when the background is not black. The other thing I have learned from experience, the hard way, is that I don't center the images in the field. I push them out as a habit, that because people at the back rows are often not able to see if you center them. There's no need to center them in the film. There is no need for aesthetic. What is that you should be able to see? So if you're going to be presenting in a large hall, it is much better to have your stuff right at the top of the screen rather than at the bottom. That's probably important. The other thing is that I crop the images completely. I show just what is required. I don't show soft tissues, I don't show abdomen, I don't show anything. I take trouble to crop. It takes few seconds to do that. But making a professional, I don't say making a professional, making a good image presentation is important in radiology, is perhaps important in all of pediatrics or any medicine it is. So when you have images like this, the image on your left shows a soft tissue. Now, this is another thing. I mean, I don't know how to go on with that. You have to have the habit of talking about images that you see. Pediatric residents look at the images like that, see the patient, you already seen the patient, and you mentally make up what to do. You don't talk. But in your exams, you're expected to talk on X-rays like you're supposed to talk on patient material. So you have to create that habit of talking to each other on ground or wherever, or in your conferences or meetings, that you have to use words when you see radiology images. So you have the soft tissue mass in the right upper zone, close to the mediastinum, which has these crenated margins, right? You can see that these are crenated margins. The crenations don't correspond to the posterior ends of the rib, but they are in between them because they are costal cartilages. I repeat. So when you look at that and you look at that, this stuff is gray here, you know that this is Thymus. This fellow is also crenated, therefore it is Thymus. Now, this is something that you make 100% diagnosis of. No suggest clinical correlation. That even as a radiologist, I get bored when some radiologists write suggest clinical correlation, as if he has to write that for the pediatrician to clinically correlate. I mean, that's plenty stupid. Anyway, so when you see that, you're sure that this is Thymus. You don't have to do a CT scan. You don't have to do anything at all. And this X-ray on your right is about 3 weeks later, and the Thymus is gone. So why am I saying this? That when you have confident knowledge of the fundamentals of chest radiology, you will avoid a whole lot of unwanted investigations. Anytime you ask for a CT scan, especially in Lobe, I'm addressing residents. All of you senior pediatricians have to excuse me because my talk is meant for pediatric residents, right? So whenever you ask for any radiological test which is invasive, now pediatric CT scans are invasive. For most part, they are done under sedation. For most part, sometimes they are done under full anesthesia with intubation, so on and so forth, and it is no fun. It's no fun for the patient. It's no fun for the mother. Starving children overnight is no fun. When you actually require just 3 or 4 hours of starvation, starve overnight is something that is not required at all. So when you ask for a CT scan in a but you be aware that all this happens. The cost is a different issue altogether. So you should be confident and fully aware of what can be made out on plain film so that you reserve CT scans to as few cases as required, absolutely required. If this were my bachu, will I do a CT scan? Will I keep the child starving overnight? Will I have the mother and the child spend a sleepless night because somebody wants GA for the CT scan tomorrow morning? And as has been said repeatedly during the introduction to this talk, plain film obviates the need for CT scan. Talk to your senior pediatrician. They will not easily be asking for CT scans in Lobe. So this is the level of confidence that you should have when you're looking at the Thymus on plain films. Okay, now this is an important slide because it talks about fundamentals of interpretation. Now in children, the other thing that pediatric residents should be doing whenever you can is that whenever something is being done in radiology with your patient, accompany the patient to radiology at least 2 or 3 times for each procedure. When, of course, plain films are being done, you may or you may not go. but it's a good idea to go even when plain films are being done. When a CT scan is being done, for example, what all the child goes through when a CT scan is being done, what all is being done, goes through when an MR is being done, or for that matter, ultrasound, or an occasional barium study. It's huge learning for you, just once. You just have to do it once, and you know exactly what all happens when you send a patient over to radiology for that. The other benefit of that is that the radiologist gets to talk to you. So he knows exactly what you're looking for. So it's learning for your colleague in radiology. So I would strongly urge all radiology residents, all pediatric residents to spend some time in radiology when you can, and I would urge teachers in pediatrics to allot, say, 15 days time for a pediatric resident to rotate through radiology so that you know exactly what is going on. That useful time in 2 weeks in 3 years is not much. That is a good rotation that you will learn a lot from. So why am I saying all this? When you do accompany a patient for a simple X-ray, when you look at this film, you know that this is not normal. Not normal. 2 or 3 things happen here. Most of the time, the child is supine on the table, crying away to glory. You have the mother holding the arm like that, and you have somebody else holding the leg like that, and the child is doing Bharatanatyam in between. For the child, it's no fun. For the mother, it's no fun. Anyway, because the child is supine and the hands are up like that, you do not get the adult type of AP view or PA view. You get a view like that, which is often referred to as a lordotic view, where the clavicles are way up. That's because the arm is held here by the mother. So that's the first distortion that you have in many, many pediatric X-rays. You get what looks like what is called the lordotic view with the clavicle up. The other thing that happens in chest X-rays when the child is being exposed to the X-ray, the child is crying to glory. Most children will cry. They are scared. The table is cold in an air-conditioned room. Fancy machines outside. Most children will be crying. They're crying, 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 crying. And then they stop, take a breath, and cry again. So the radiology technician who has been told you should expose the film in deep inspiration cannot do it most times because this inspiration happens just for a few seconds. And because the child is crying, in a normal child, when you take an X-ray of the chest, most of the time it's an expiratory view. That means the volumes of the lung are less, not big and wide like this. Why am I spending so much time? This is fundamental. You have to understand this. Therefore, if you see a nice normal inspiratory film in a child, your antenna are up. This is not normal. This is true till at least about 5 years of age, after which the child may cooperate for taking a deep inspiration and holding. A nice, normal, deep inspiratory film in a child who is less than, say, 5 years of age is something for suspicion. You have already seen the child. This is some child with a respiratory tract infection. You see something like this, and an average radiology resident will call it normal. An average consultant in radiology who doesn't do pediatric work will call it normal. This is not normal. This is as abnormal as it can get. What is happening here is that in spite of the child crying to glory, the alveoli cannot collapse because they are held open by inflammation in the respiratory bronchioles and the alveolar duct by viral infection. So this is a classical picture that you'll get in viral bronchiolitis. Child with cough, fever, breathlessness, and you have an X-ray like this, you have a pathological diagnosis or a macrobiological diagnosis of viral bronchiolitis. This is not normal. A deep inspiratory film in a child like this is not normal. I repeated this for 7 times. I usually do it 10 times. You're lucky. I did it only 7 times because this is important, because this is true every single time till the age of 5 years or so. So once you have this, an image like this in front of you, and you've already seen the patient, you are not surprised. You say, okay, this is a classic of viral bronchiolitis. Keep it in teaching file, your teaching file in the department for somebody else to learn from. You can do that even if you are resident. Keep a repository of images for somebody else who comes after you to learn from. So that's sort of teaching when you are already a resident. Okay, so 2 things are important. The third thing that is important here is that you have to look at rotation. And I told you at the beginning that rotation is a big deal as far as children are concerned. Small amounts of rotation can make a big difference as to how the right lung and the left lung look like. Now, I had a teacher in surgery when I was a bachu I was a resident in, no, I was a medical student. And that was 73, and long back. And he used to say, he called every student boy, okay? I mean, I don't know what he called girls, but he said, boy, God has given 2 hands to compare. It's very useful. Simple, basic thing, God has given 2 sides to compare. And I had a neurologist who look at the pinna of a child and say, this child has had infantile hemiplegia, some stuff like that, 2 sides to compare. So here on the chest film, you have 2 sides to compare, but they are not comparable because whatever reason, I'll show that a little later. But you have to look for rotation on the film. And you have been taught in your undergraduate days that you see or look at the distance between the medial ends of the clavicles and the midline and say whether it is rotation or not. Fine, it's not rotated, good enough. But I told you, there's Bharatanatyam that happens on the X-ray table. Somebody is holding the clavicle, I mean, the hand up. So the clavicles don't move. So the clavicles are unrotated. Somebody is holding the hip. So the hip doesn't move. But the child is rotating in between. You'll see that in radiology department. Therefore, you can have gross rotation of the chest even if the clavicles are normal. How do you tell that? You look at the distance between, can somebody tell me if you can see the pointer or you can't see the pointer? Okay.
We can see the pointer.
Great.
Yes.
So that makes life easy. Sometimes when I share screen, people don't see my pointer, or so they say. So you see the distance between the medial ends of the ribs on the 2 sides and see if they are equal, right? If they are more or less equal, you know that the whole film is unrotated. Clavicular rotation is not enough. A non-rotation of the clavicle is not enough as far as pediatric chest X-ray rotation is concerned. So you automatically will look at the anterior ends of the ribs to see if there is rotation or not. That's how you look at rotation. Rotation is a big deal, absolute big deal. Not as much in adults, but in children, it is very, very important to deciding how the 2 sides look like. Okay, now, if you have an unrotated film, so that's something that you do automatically. In children, you have to do it. When you're describing in an exam, you can say it is an unrotated film, and you can show off, saying that the clavicles are equally placed, the anterior ends of the ribs are equally placed, and the examiner, who may or may not know, will ask you, why are you mentioning the anterior ends of the ribs? And you can show off. Exam is a game of showing off what you know and not showing off what you don't know. It's fun. You have to be smart in an exam to show what you know. Okay, this is one thing that you can show off. Okay, so the anterior ends of the ribs are where they should be. This is an unrotated film. And then comes what I pompously call Ravi Ramakantan's radiology rules, 4R. You can't beat that. No one can beat that. Ravi Ramakantan's radiology rules. And that rule number 1 was that in an unrotated film, you should be able to sing a song. Okay, all of you sing a song. In an unrotated chest phone, you should be able to see some part of the heart on the right side of the right border of the spine. That is the song. Should be able to see some heart on the right side of the right border of the spine. That's normal if you can see. And if you don't see, it's abnormal. That's important. It's not naam ke vaste. Okay, those of you who are from South, sorry. It's not a rule for namesake. In pediatrics, it's extremely important. It can be life and death. It can decide whether you will do something immediately. It can decide whether you will at 2 a.m. in the morning ask for a CT scan. Some part of the heart should be seen on the right side of the right border of the spine. The important caveat is that it should not be rotated. A little bit of rotation and this rule doesn't work. But something like this, where it's reasonably unrotated, you will be able to see. Let me time myself. Oh God, I always finish 1 hour. Don't tell me. I have this crazy knack of talking. Anyway. So that's an important rule. It's an extremely important rule that will determine what you do next on your call when you're on call at 2 a.m. in the morning. Why 2 a.m. in the morning? It's just a number I comes to the top of my head. 2 a.m. in the morning. Okay. So that's the first thing that you should be aware of when you see a film like that. So Ravi Ramakantan's radiology rule number 1 is that anterior ends of the ribs should be equal. So I keep changing 1 and 2. And number 2 is that there should be some heart on the right side of the right border of the spine. I literally drill this into radiology residents. You're lucky that you are not. And I tell the whole class to say, repeat. Some heart should be seen on the right side of the right border of the spine. It's fun. In a large hall of radiology residents, 200 of them, they're repeating this like a nursery rhyme. Okay. What else is normal? When you have an unrotated film, and let me go through this very quickly, right? The left heart border, the top is the aortic knuckle. Following that is the pulmonary artery. This one is the pulmonary artery. Till about, let me see, till about 10 years of age, you will normally see a prominent pulmonary artery. And in some girls, you will see it up to 18 or 20 years of age. That's normal. How do I know? Because I'm telling you. How do you know? You will see it in your life again and again and again, that this is normal. Seeing a prominent pulmonary artery does not mean pulmonary hypertension. So that's the aortic knuckle here. And that's the pulmonary artery, which brings up another useful rule. Now, that's not something that is always useful in pediatrics for reasons that I will explain to you. Now, when you examine a patient in the respiratory tract, at MBBS start with the suprasternal notch, see if the trachea is in the midline. As far as radiologists are concerned, the trachea is at the carina. We don't look at it high up like you do clinically. So we trace the trachea downward and see what it does as it comes to the carina. Now, I hope what the carina is. The carina is not the bifurcation. The carina is the inferior border of the bifurcation where the lower ends of the two left and right main bronchi join. So as you trace the trachea down to the carina, in children who are more than 5 years of age, it tends to go to the right. By the age of 10 years, it's always on the right side of the midline. In an older child, at the carina, the trachea is never in the midline. It goes to the right, almost always. Now, the question that you are going to ask yourself is, why does it happen? I keep asking why. Your gray cells will keep growing, right? How many gray cells do we have? Or rather, how many neurons do we have? This is an interesting anecdote for all of you. For a very long time, people used to say till about 20 years, 15 years back, it was being taught, it was literature, it was Nobel laureate stuff, that we have 100 billion neurons and 100 billion glial cells. Women have a little less, but their synapses take care of it. So it's the connection that matters. So this was published literature. 100 billion neurons, 100 billion glial cells was published literature. Till somebody in Australia, a clinical psychologist, found a much better way of measuring neurons. And that you should wonder, how does anybody calculate, count 100 billion? You can research that after this. And she has said that it's not 100. We do not have 100 billion neurons. She broke the myth of 100 billion neurons. And now we believe that we have about 68 billion, I repeat, billion neurons. And many of us are still down. And how many glial cells? Half that number. So 100 billion comes down to 68 billion and 34 billion. That's what the state of the art is. Why am I saying that? Because William Osler, I don't know how many of you have read William Osler. He's sort of my hero. William Osler is considered the father of modern medicine. The guy who said that medicine has to be learned by the bedside and not in the classroom, 1890s, okay? So Sir William Osler, and you can read about him, has many, many quotations. And one of them is extremely interesting from, again, the late 1890s. He said, and I quote, I know all of them by heart. You call me up at 4 in the morning and I will say that for you. And he said, he was talking to medical students, right? He loved to teach. And he said, in fact, that when I die on my grave, just write one thing, that I like to teach medicine by the bedside. So that's what he wanted on his grave. So he was talking to medical students and he said, gentlemen, I have a confession to make. This is William Osler. Gentlemen, I have a confession to make. Half of what we tell you will be in error. Furthermore, we can't tell you which half. That is William Osler. The interesting part here is that he started by saying gentlemen. So in 1800s, there were no lady medical students. And it's very, very interesting that the first lady medical students were in the first Indian medical school in Calcutta. They were the first lady doctors, and we should be very proud of that we have them coming out of India in the 1900s or something. I don't remember. So this is what William Osler said. So what I'm saying, don't take anything as gospel. Nothing is gospel. You will check, you will read. And more importantly, when you find that I'm wrong, I don't know about your other teachers, when you find that I am wrong, you will write back to me and say, Ravi sir, you are stupid. What you said is wrong. I learned. So I don't keep teaching the wrong thing. So it's a very healthy type of relationship between a teacher and a student. So what did I say? That the trachea goes to the right normally in children older than 5 years of age. And you ask why, and that is because of the arch of the aorta. So the arch of the aorta, and many of you have heard of the word unfolded, right? Have you wondered what unfolded really means? This is real homework. I'm not going to give you the answer to what the word unfolding of the aorta means. It doesn't happen in pediatric, but we use the word often in adult radiology, unfolding of the aorta. So the aorta, normal left aortic arch, will push the trachea to the right in children about 5 years plus. Maybe even earlier, but 5 years plus surely. So, Ravi Ramakantan's rule number 4. In children older than 5 years of age, if you find that the trachea at its bifurcation in the carina is in the midline, something is wrong. Look for abnormality, which either pushes the trachea to the opposite side or pulls the trachea from the left side. So this is useful in an older child. It is not useful in a child less than 5 years of age. It's extremely useful on plain film, especially if you're looking for subtle hyperinflation. That this is another thing of human physiology, visual physiology, has been shown again and again and again that the human eye can pick up white shadows much more easily than it can pick up black shadows. So that when you have a chest wound which has hyperinflation, you can easily miss it when you look at the X-ray like that. But when there's a white shadow like pneumonia, for example, or aspiration, or whatever, you can easily pick that up. So therefore, in children, so many things are hyperinflation, and so many things are black lung. That's important. Therefore, you have to look at it very carefully. So this is the next thing that you have to learn, that this is what happens. That the pulmonary artery is normally prominent, that the trachea gets shifted to the right at the hilum in older children, and that you have to have some part of the heart on the right side of the right border of the spine. Okay? You must be bored of this, but this is important. If you're a resident, this is useful learning when you look at chest film, starting off with what is rotation on this film. Now, look at this film. It's funny because I tried to do something to the image, I didn't succeed well. Now, this film is easy, but you follow the rules. There is no heart on the right side or the right border of the spine. You just see pulmonary arteries here, right? No heart on the right side of the right border of the spine. Therefore, something is pushing it or something is pulling it. If there's something that's pushing it, is easy. You have obstructive emphysema or whatever. But you have to look at one very important place on a chest film at any age of the patient, especially in pediatric. What we are not able to see normally, let me go back here. What we're not able to see normally is the retrocardiac lung. If the film is a little underexposed, you will not, I mean, there's a whole lot of physics involved. How you look at the film, whether you're looking at it on a monitor where you can play around with the image or looking at the film, and how you look at the film, I've gone into that. But you have to have the habit of looking at the part of the lung. Now, it should be easy for you because you examine the child and you are getting some foreign sound posteriorly. So you know that it is left lower lobe, for example, and therefore you will look behind the heart. Now let's look at the next image. To look carefully behind the heart, you will see that these bronchial markings are crowded, like you see it on a coronal image of a CT scan. Rule number 6. Normally, bronchi are not seen on a chest film. Normal thickness of the bronchi is not seen. So there is no such thing as bronchovascular markings. The so-called bronchovascular markings are nothing but vascular markings. And bronchi happen to be with them is incident. Okay. So what you see here, and all of these markings that we see are on the previous image, all of this is not bronchovascular marking. You will see it ad nauseum in radiology report, prominent bronchovascular markings. What does it mean? How should I know? You are the pediatrician. It's your problem. So there is no such thing as bronchovascular markings. These are just vascular markings. Therefore, when you see prominent bronchi here like this containing air with air bronchogram and they are crowded, you know that this is behind the heart, therefore lower lobes. The bronchial markings are close to each other, therefore there is loss of volume, therefore there is no heart on the right side of the right border of the spine. Looks like mathematics. Therefore. That's fun. When you say therefore, there is no remembering involved. It's a simple logic. So you start off the other way around. On call, you see that there is no heart on the right side of the right border of the spine. You start looking. If there is something on the right side, which may be black stuff like pneumothorax, it may be obstructive emphysema, it may be pleural fluid, which is easy to pick up. Or is there something often hidden behind the heart, which is pulling the lung to the opposite side? So one rule, many benefits of picking up that on our chest film at 2 o'clock in the morning again. Now look at this. This gets a little tricky. Okay, you are on call. Here is a child who comes with the mother. Both of them are beleaguered. Mother looks all black. swollen eyes, not slept. The child is crying. It's 2 o'clock in the morning, my favorite time. And you are shown this X-ray. The radiology resident is sleeping in his room, no one to help you. What do? You think of RR rules. RR rule number 4, 5, whatever it was, there is no heart on the right side of the right border of the spine. Therefore, look hard. Is there something that is pushing it to the opposite side? You don't see. You see normal vascular markings here. It doesn't look black. Nothing is happening there. Is there pulling it from the left side? You look hard. You're smart. And then you say there's something wrong there on the left side. It is looking black. It looks different. Therefore, you come to Dr. C.V. Patel, that famous teacher of mine, who taught me that God has given 2 sides to compare. But for God's sake, there's a heart in the way. How do you compare the left and the right? Because the heart comes in the way of all sorts of rational thinking. It does really in life. You learn. Okay. So what do? You get rid of the heart. Simple. So how do you get rid of the heart? Now let's see what happens when you get rid of the heart. Has anything happened? No. So how do you get rid of the heart? You take a hand, put it there on the phone or the monitor and get rid of the heart. And then, I don't know, there's something happening here. There should be something happening. There it is. Okay, this damn thing doesn't work from keyboard. So this is my hand, just for illustration. You can take something and put it there. And you compare the right lung and the left lung, get rid of the heart. And then it's fairly easy to see that this is blacker on the left side compared to here where there are vascular markings. Now, the question is, why is this black? If this was black, most of the time we tend to think of that as obstructive emphysema. If it is obstructive emphysema, it should be pushing the heart to the opposite side. Now see all the therefore. The heart is shifted to the left and there is hyperinflation of the left lung. Now this is high profile radiology, hyperinflation, black lung, often missed. You have a child with a foreign body, subtle hyperinflation, almost always missed. Now believe me when I say this, that I have in all my career found that the first X-ray of a child with a foreign body which has hyperinflation, the hyperinflation is missed every single time. You don't believe me? Yeah, I might be lying. So this hyperinflation stuff is something that people tend to disregard or not pick up at all. But you are smart and you know that there is hyperinflation. Therefore, you expect that the heart should be shifted to the opposite side. But it is not shifted to the opposite side. It is pulled to the lateral side. Therefore, this hyperinflation is not obstructive emphysema. It has to be compensatory emphysema. If it is compensatory emphysema, it should be compensating for something. And that compensation should be for loss of volume in somewhere in the lung. You don't see loss of volume, which will be white stuff, in the upper part of the lung, and you are smart and you will look for it behind the heart. Now this is where looking carefully is important. How did we start off? We saw no heart on the right side of the right border of the spine. We saw blackness on the left side. We scratched our head and said, there's something unusual here. I have to look for loss of volume. Look carefully now. This is not easy. You may not even believe me, but it is true. Now you look at black lung and you look at gray heart and you trace medially, you'll see a vertical line here. You can actually see it here. And that is the collapsed left lower lobe. And you'll see better images on collapsed lower lobe. But this is real life, where it was not obvious, but you're looking for it. Because maybe the breath sounds are less. But in a child who's crying away to glory with a foreign body, what are you going to hear? Breath sounds less. You may, because there is compensatory emphysema. But if you did pick up decreased air entry, the left lower lobe posteriorly, you look for it and you will see the extremely subtle sign. You'll pick up subtle signs when you look for them. There are two things two ways of looking at anything, whether it is patient or whether it is radiology. You look at something because it's staring at you. You look for something because you want to look for it, because you wonder if it is there. Now, looking for something comes from knowledge or from experience. And looking at something is what I call as Akash fallacy. Google Akash fallacy, and you will know what I mean when I say that pediatric residents, radiology residents, no medical student should fall into the trap of Akash fallacy. So looking for something comes from logic. And this is one logic in small part of radiology. I'm sure it works in all of clinical medicine also. So when you look carefully, you will see this shadow, which I'm sure many of you don't even believe exists. You may not see it on a monitor. I'm using a medical grade monitor, so I can see it very easily. But if you're looking on cell phones, you're going to miss it. Cell phone radiology has to stop. WhatsApp radiology has to stop. My wife will show, she's a radiologist, and show me images. Ravi, what do you think? I said, WhatsApp, I'm not looking. Because if somebody is asking my opinion, I cannot see it on WhatsApp and say this is normal or abnormal. I want it on, at least on email, so I can look at it on a proper monitor. People think I'm fussy. I'm just smart. I learned from experience that if you want to make a diagnosis, look at it carefully, not WhatsApp blue images. You will miss findings. And people tell me now, this I have to stress on this. People tell me that we pick up many findings. It's not about what you see on WhatsApp images. It's about what you don't see. And you never know that you didn't see if you didn't see it. So as far as possible, I don't know, there are real life limitations that you may have to look at it on WhatsApp. Avoid looking at cell phones. At least look at proper monitors or laptops or something, because cell phone makes everything so small, and you magnify it, you lose resolution. I mean, it can be criminal. I mean, in a court of law, if you said that I made a diagnosis on cell phone or whatever, you will be behind bars. That's medical negligence. You cannot justify it. Even if you say I find it on laptop, that is not allowed, because you are supposed to have medical grade monitors as far as radiology is concerned. That's beside the point. Okay, now, therefore, you have to see this double density behind the heart. Now, what will happen now? Suppose you are not so familiar with this, okay? And you're hearing decreased breath sounds there. You suspect foreign body. At 2 o'clock in the morning, you'll ask for a CT scan. That will not get done till next morning, 9 o'clock, because anesthesiologists are not available, or the radiology resident is not available, whatever. There were times when a resident where diagnosis would be made on plain film, and the child will go for endoscopic bronchoscopic removal of foreign body. Now what happens is, the plain film is done, then you do a CT scan, then you do a 3D volume rendering, and then you remove the foreign body. No one has ever shown that results have improved with all this masala. It's slightly better. The problem is that on plain films, findings are missed. And as I told you, hyperinflation is often missed on plain films in foreign body. And I can narrate a personal example of a child very closely related to me who suffered because somebody missed an obvious foreign body on the first image. The child was almost in cyanotic spells and rushed to a hospital, and a foreign body after the peanut had to be removed at some 4 o'clock in the morning. This I know for a fact. So I'm very touchy about missing foreign body findings on plain film. So that it is a foreign body is incidental. That this is a finding is real. So you have to be aware of subtle findings on plain films. Look behind the heart. Now, if you have digital radiology, if you have patch system or whatever that means, you can play around with the image, make it darker, lighter, so on and so forth. Life is so much easier when you look at it on monitors, and you can see it's like having 10 films of different densities, and you can look behind the heart, behind anything, and see a lot more. So this is about comparing the right side and the left side and the rule that there has to be heart on the right side of the right border of the spine. Okay. So this is what we went through. Something happening, some part of the image is getting cut off by. Okay, so let me see if I can see it. How do I get rid of this? Maybe I have to get. There's something here. Can you people see my monitor? And can you see something here? Here for me, something is overlapping here. I mean, I should have anticipated this. Let's do one thing. Let's move on. This won't work till I have that part C. Okay, now let it be. Okay, now let's do this. I do this exercise in a huge lecture hall, and I want to do this with you, and I want you to please follow what I say. What am I going to say? Take out your cell phones. Just follow instructions, right? Your cell phone in your pocket, your cell phones in your bag, your cell phones within a bag, take them. I'll give you 10 seconds. And please, I want all of you to do this for me. Once you're talking your time phone, look at anything that is in your vision, right? Anything in the room, anything outside the room. If you're in a park, a beautiful flower, any damn thing, look at anything. Take a picture. Now, I hope at least 10% of you have done this. I mean, in a lecture hall, I can do dadagiri. I said, you do. Here I can't. So let's see that you have looked at something and you have taken a picture. Now, look at that photograph on the cell phone. Beside that thing that you looked at, you took a picture of, let's say it's a flower, you see 1,000 other things on that image that you did not even know existed when you're taking that photograph. This is an extremely important point about how you practice radiology. And unfortunately, because my stupidity, I cannot show what happened. But when you are looking for something, that's what happens when you are a pediatrician. You are looking for pneumonia. You are looking for foreign body. You are looking for pneumothorax. You're looking for pleural effusion. You look for it, you find it, or you don't find it, and your story ends there. So you're looking at it, that's all. But in reality, that image has a lot more information, and that has been taught in clinical medicine all along. You examine a patient for a neurological abnormality, palpate the liver, palpate the spleen, whatever. Look at the patient, look for lymph nodes. So in pediatrics, you are taught to look at the patient as a whole, and that works in radiology. So if you have a chest film, if you have a CT scan, you have an MR, you have a PET scan, don't stop when you have found what you were looking for. And that image on your cell phone should be with you all your life. There's a whole lot of other stuff that you did not see because you were not looking for them. And that's very, very true of radiology. That there can be other findings that may add value to your diagnosis that you were looking for or looking at, depending upon what your clinical diagnosis was. Okay. On this image, in fact, there is a finding here which I cannot show you unless I go out, edit, and come back. It doesn't matter. Let it go. Now look at this image. This is fantastic. Absolutely. This is a patient who has had surgery for congenital heart disease. Look at this image for about a few seconds and see what you see. You see collapse in the right upper lobe, right? Here there is soft tissue here that goes back towards the trachea. The trachea is still in the midline. The endotracheal tube is little this side, so most of you will pick up loss of volume in the right upper lobe. But this child is not doing well, disproportionately unwell. Therefore, the pressures on the ventilator are sky high. You look carefully, and I'm not sure you will see it here unless you're aware that there are air pockets within the lung, and this is interstitial air. That's not what I'm trying to show you. I'm trying to illustrate Ravi Ramakanthan rule number 100. Look at the whole image. Look at the whole image. Look at everything on this image from head to toe. And you will see there is a scrotal hernia. Does it matter to this patient with congenital heart disease? No, maybe not. But this hernia can get obstructed anytime. And as a doctor in charge of the patient, you'll want this fixed as early as possible. It's also possible that this scrotal hernia can undergo torsion and become acutely now or a little later. But this is a finding that's important. Had you just looked at the chest film and forgotten about it, you'd probably miss that. I do not know how many will pick this up. And the other rule then is that you will miss findings if you do not give enough time for every examination, whether it's a patient or the radiology. I don't know how much that time is, but up to a point, your findings keep going up and then it levels off. And that's something that I don't do. I make mistakes because I'm in a hurry for no reason at all. I look at X-ray like this, 10-second normal, 10-second this, 10-second that, and I miss findings after 40 years of radiology because I don't give enough time. There's no alternative to giving enough time. 1 minute, 2 minutes, 5 minutes, I don't know. But you have to look at everything as a habit. And that habit is when you're 25 years old, a first-year resident in pediatrics. And you will not miss finding. Here, it may be an incidental finding. Somewhere else, it may be real finding, which nobody else will know because no CT scans are done and nobody is going to examine the scrotum for a patient with congenital heart disease. But anyway, nobody examines scrotum often these days. And so often, nobody examines anything these days. And it's a huge tragedy of clinical medicine. So this is one part. Look at everything. Like the cell phone thing, you will miss things if you don't look at everything. Now let's move on. So there's an old thing that there's some saying somewhere, a black cat comes twice. Look at the trachea, right? You start off with the trachea. This trachea at the carina is gone to the left. It's not even in the midline, it's gone to the left. Therefore, look for something on the right, which is pushing it to the left, or look for something on the left, which is pushing it to the left. And when you look carefully, not even so carefully, just look at it, you see that this child has a right aortic arch. A right aortic arch is one of the, even though it's not so common, but for something like this, subtle displacement of the trachea to the opposite side at the carina is often produced by a right aortic arch. What the right aortic arch means in a perfectly normal individual is a different thing, but what it is in a patient with cyanotic heart disease is something else. So this is an illustration of how, knowing one simple fundamental rule, you will pick up lymph node. It could be right aortic arch, it could be lymph node, it could be some other mass in the superior mediastinum, small, hidden behind. That's the importance of chest radiology, not to make a diagnosis of what it is, but not to miss a finding when it is there for somebody to see, just because you didn't have information, insight, or patience to look at a chest film properly. So this is a very dramatic, and this happens often. And I don't know, I'm not saying it happens every day, I'm not saying it happens every week, but it happens often enough for you to remember that the trachea, the bifurcation is on the right side of the midline in children older than 5 years of age. What time do I have? Half an hour? That's fine. Okay. It will be a record performance. I'll probably get to the last slide in this lecture. So, this is an older patient. It's not really a child. She was, pediatrics keep changing. Sometimes it's 12 years, sometimes it's 18 years, sometimes it's 19 years. It depends on who the pediatrician is. So this is an older patient in the teens, and this is what was seen. Now you have to learn to describe this. So you can describe it as a soft tissue haziness in the right upper zone. Now we are good at describing because we've been doing that day in and day out. So there is something here which is abnormal. Now, all that you know that there is something here that's abnormal. Clinically, this is a walk-in patient for pre-anesthetic workup, and you wonder what's going on here. And if you ask me, I know the diagnosis because I've seen several examples of that. And that is there in my temporal lobes. I know what the diagnosis is. And the person who saw this called this a soft tissue haziness, and a CT scan was done. The CT scan was normal. This happened in KM Hospital. And the next morning, the resident showed this to me, and I said, there is nothing here. This is normal. And the resident said, sir, how do you know? You must have seen the CT scan. I said, I don't look at CT scan, but I know it's normal. This is not inside the patient. This is outside the patient. It's a chotli, the plate of hair. And you look carefully, you can see actual plate of hair here. You can see something like this, going like that, going like that. And you can see soft tissue shadows here. As I told you, unless you see it on proper monitors or phones, you will not be able to see it. The other thing here is that you have this mental impression. Plates of hair always look like this. What is this? It looks like this. That's all. You don't put it in words. It's not easy. They look like this. They are out of place in a clinical situation. You do CT scans, you don't see them because it's on the surface, and the way we window for lung, it's burnt out. It's black. You don't see it. But there are certain brands of oil that make it really opaque like that. So the next rule is that everything that you see on the chest bone need not be inside the chest. It can be extraneous like this, or it can be on the chest wall. It can be a lipoma. It can be something else on the chest wall. And remember that soft tissues like this have to be looked at carefully. Something in the apex of the lung. I used to teach that something like this, disproportionate in the apex of the lung in a female patient is hair. Now I'm not so sure. Female patient goes out. Everybody has big hair and ponytails. But something like this. Now this is radiology. Something like this. It's difficult to put it in words. Like interstitial lung disease, an appearance like this. So that's visual memory. And you see a few of them that falls into your mind, and you will be able to trace this and trace this outside. The important thing is to be able to trace it outside the chest wall, and then you are sure that it is outside. And what I tell radiology residents, call the patient and see how the hair is. Most of them, they don't change fashions every day. So if this totally they're tied up like that, you know that it was the hair that was there. Of course, the simple thing would be to repeat an X-ray and it's not there with the hair being removed completely. This is bad radiology technique. In the first place, it was not supposed to be there. It was up there. Anyway, so this is something that you should remember. It's possible that something that is overlying on the chest need not be inside the chest. It may be on the chest wall, or it may be something completely extraneous. Now, it looks stupid, but that's an important rule. Now, this is important. Okay. We have this pediatric radiology meetings at KEM on Thursdays, and we have this poor Bachu look, pediatric residents presenting cases in front of me. When Bachus present cases in front of me, I became a murderer. Okay. Thankfully, I've never been an examiner. I would have been very unpopular. So this Bachu showed me this X-ray. Child came with cough, fever, masala. Sometimes you never know it's pediatric resident. This is a full-time normal delivery, immunized completely. The boy is 11 years old. How does it matter? but they do all sorts of things. Anyway, so this was shown and the history was given. And I said, what do you think? Now, when I don't know what's going on, I always ask the bachulu, what do you think? It's a good idea. So he said, sir, I think it looks like a pneumonia. We started with antibiotic, oral antibiotic. What did you do? Oral antibiotic. We did as X-ray. Next day. What the hell for? It makes no difference. You cannot see changes in the pneumonia like this in one day. But anyway, they repeated an X-ray. So the third day, the child was still spiking. Therefore, what did you do? We repeated an X-ray. And we repeated an X-ray. This went on for a week. The child is still spiking. And then I said, what did you do? And so this goes on for a long time. It went on for a very long time. That's why this favorite case of mine. And this Bachu was very smart. And then he said, I said, what did you do at the end of 10 days? And he said, sir, we did this, a lateral view. Now, I keep teaching that when you don't know what's going on, do a lateral view. A lateral view is extremely useful. And I told right at the beginning why we don't do it often. Because we are not comfortable. Therefore, we don't do it. Therefore, we are not comfortable, so on and so forth. Now, when this Bachu told me, sir, we did a lateral view, I was jumping for joy. After so many years of teaching, these Bachus have learned that we should be doing lateral views when we don't know what's going on. See this Bachu, 10 days of oral antibiotic, then the child goes on intravenous antibiotic somewhere, still spiking to glory. And he said, we did a lateral view. I congratulated him, all that. And then I asked him, why did you do a lateral view? And I expected him to say, sir, you have taught us, therefore I did it. And this Bachu was innocent, down south. Sir, we did a lateral view because the child complained of backache. Gone. All my high is gone because the child complained of backache. Okay. So anyway, the child complained of backache. What do you see? Now, here is an example of how you look at lateral views. I don't have many X-rays of lateral views here to show, but there are some important rules, very useful, simple rules that you look at for on the lateral view. The first and the most important rule is that the retrosternal area is black. There's nothing there in a child. There's no big aorta, nothing. Even if there is a thymus, it tends to be black because the thymus is more often not black. If there is a big thymus, sometimes you may see a soft tissue shadow there. The more important rule is that this, listen carefully, it's important. As you trace the vertebrae down from above downward, the vertebrae become more and more and more and more black. What will you do? You will ask why. Why does it happen? That normally, as you trace the vertebrae down from D4 to D12, on a lateral view, they look more and more black. So there's a why there. It's homework for all of you. Think about why that happens. It's very easy. Actually, it's very simple answer. So, but that is the truth. When that does not happen, when it does not become more and more and more black, and it becomes white like this, you know it's 100%. No exception. Abnormal. It's something worth looking at. What was happening here, of course, in the child, was there was a pocket of fluid here. If you have an empyema, nothing is going to work. And this was just not seen on the plain film because it is below the dome of the diaphragm on the plain film. It was seen only on the lateral view. So the pigtail catheter was inserted in that, the pus came out, and 2 days later, the child was afebrile. So this is an unfortunate story of not thinking lateral, of lateral views, when it should be done when something is not going right. I put it up. I don't usually do this. I put this up because this is important. Now, rather than nowadays people do CT scan. Who will do lateral? Who knows how to read lateral, so on and so forth. I know the reality of the world today, but all the same, I feel that it's something that you need to remember that it's much simpler to do a lateral view and to learn how to read a lateral view based on these two just simple rules, that the retrosternal space, okay, the retrosternal space should be black, and that as you trace the vertebra from D4 down to D12, they should become more and more and more black. Okay, that's all that you need to remember. Okay, look at the soft tissue shadow here. What do you make of this? What's interesting here? No, I mean, I should not use the word interesting because I feel that every interesting case is an unfortunate patient. I mean, we call them interesting cases, but in reality, they are unfortunate patients. And there's a big story that goes with that happened in the department, not for this audience. No, when I'm live, I'll talk about that example of interesting cases or unfortunate patients. So when you have a soft tissue like this, you see that the trachea is shifted to the opposite side. It's here, right here. This is the left main bronchus, which is compressed, and the trachea is shifted here. What do you make of that? How do you make of what you make of that? You know that it is abnormal, and to tell what this is, you have to look at everything that's there, and it takes time to look at. Now, there is an important rule here. Both radiologists, I mean, at least radiology residents, almost all pediatricians, both of them fail to look at bones. It is not immediately obvious that you should look at bones because it happens so infrequently. And my teaching is simple. If you have a patient who has a pleural lesion, clinically and radiologically, the first thing you look at is the bone. You ignore the soft tissue shadow and do whatever you can with the image manipulation and look at the bones, especially if there is tenderness on the rib on clinical exam. It works like this, that if you have tenderness on the rib, the X-ray may not show bone destruction. But if the X-ray shows bone destruction, there has to be tenderness on that rib or in that area. Now, when you compare this here, you have a soft tissue mass, a soft tissue abnormality in the left upper zone that is displacing the trachea to the opposite side, which is compressing the left main bronchus. That's all that we see. But if you compare the ribs on the right side and the ribs on the left side and spend few seconds, that's all it takes, 10 seconds, 15 seconds. God has given two sides to compare. It's very easy to see that the ribs are splayed or widened on the left side. Every rib space from this side, for example, versus this side, or here or here. So the ribs are widened. What does it tell you? Whatever is there has been going on for some time. And the next finding is very difficult. I mean, I'm not sure you'll be able to appreciate that. What you see here is that the rib margins are scalloped. It's like that waves, and they're like that, like that, like that. What does it tell you? It tells you that this fellow has been there for a very long time, trying to find its place, not enough place, pushing the trachea and the main bronchus. So he has started making impressions on the ribs. So this is really, really long stuff. But this lesion has not eroded or destroyed the ribs. So this is a long-standing, non-aggressive lesion. Now, it's possible for you to think that why do all this thing on plain film? Why pick up all of these things? I see something, I will do a CT scan, I will do a CT scan guided biopsy, I will have the answer. That's fine, that's perfectly okay. But you may not have to do that every single time. If you are able to pick up other findings or this finding on plain film. On plain film, therefore, you know that this is a soft tissue tumor that has been there for a very long time. It's a slow growing tumor and not a malignant tumor. This was a ganglioblastoma. in the lung. It's an unusual tumor, but this was a benign tumor. So the fun of plain film radiology is that you know what it takes to say benign versus malignant. You know what it takes to say when you require a CT scan or not require a CT scan. You know what it takes to know if there is a finding or a not finding. So if you know all this, the number of times you will do a CT scan will become less. So the whole concept is you picked up the finding, you have, for you, it's so good. You know what the patient has come with. You put two and two together and you know that I need not do something more. It's not as if I don't see something on the plain film, therefore I will do a CT scan at a drop of anything, drop of hat, forget it, drop of fan. CT scan, plain, plus contrast SOS, chest, child, and the child is crying, the anesthesiologist is crying, the radiology resident is crying because he doesn't know what he is looking for. It's no fun. I don't know how many of you have had CT scans done with contrast or even without contrast. It's not fun. Even if it's a plain scan, there's anxiety of what's going on. And when it's contrast, it's not fun. So adults, it's not fun. In children, it's definitely not fun. I'm saying this because it's so important to put yourself in the position of a patient before you ask for any invasive test or, for that matter, non-invasive test. So this is an example of how looking at the left and right tells you that this is a benign, slow-growing tumor. That's it. You got that diagnosis. The rest of it will come, of course, with a biopsy. Whether you need a CT scan biopsy or not, it's a different question. You can just stick in a needle there and still get a good biopsy. In fact, that was my dissertation. Fluoroscopy guided biopsy for lung lesion. When was that? 1979, 1980. Okay. So we move on to some more basic findings here. Now, this can be called normal. It almost passed off as normal till you saw this here. This is a typical appearance of partial collapse of the right upper lobe. And the trachea, as you can see here, right here, not here at the carina, is shifted to the right. Now, when you see something like this in the apex of the lung, you tend to think of this mostly as parenchyma. But in a supine child, fluid in the thorax collects at the apex. You don't look for pleural effusion here, look for collection like this in a supine form, because that's the most dependent part in a supine patient. Okay, there are other findings here. We do not go into this. Now, this is simple, straightforward spot diagnosis, staphylococcal nematoceles. I mean, there are other differentials for this, but this is what you see. But the important thing when you have staph nematoceles is to look for and follow up for pneumothorax, which will occur catastrophically in a small proportion of patients. Now, you look for it on supine film. I'll show you examples of how to look for pneumothorax on supine films. So this is an example, dramatic example of how pneumothorax looks on supine films. Very easy. It's very dramatic because it is contrasting with a lung which is completely white. Yeah. If the lung were normal lung, you would not see it like this. So this is where air collects when the child is supine in the supradiaphragmatic region. And if you're looking for pneumothorax, decreased air entry, you look for it here. The reason I'm showing this is something extremely important. Yeah, pay attention. Not many people are aware of this entity. If you thought that this was a small pneumothorax, you are wrong. What this pneumothorax is doing, this is the dome of the diaphragm. This is also the dome of the diaphragm. The convex upper part is the anterior part because of the liver, whereas the lower part here has to be the posterior part. Now, normally when the dome of the diaphragm goes down, it becomes flattened. this one, which is concave upward, this is something that you have to pick up. It's important. This is concave upward, and this is called reversal of the dome of the diaphragm. The diaphragm, instead of being convex up or straight, has become concave up. Why is this important? Now, how many times have I told you why is this important? Because when this happens, the diaphragm does funny things. In normal expiration, when the diaphragm is supposed to go up, this dome of the diaphragm goes down because the whole mechanics, whole axis of contraction changes. You can work out the physics in your mind. So this is in inspiration, this is in expiration, this is an expiration, this is an inspiration. Physics, what will happen? Air will flow from left lung to right lung to left. No gas exchange happens. And this phenomenon is in German called as Pendelluft. Like a pendulum, Luft, you know, Lufthansa, air, okay? It's like a pendulum going from right to left, and therefore there is no fresh air, no matter what you do. This air is just going from one side to other, so you keep on increasing the ventilator pressure and you end up with barotrauma. So you have to recognize this doesn't happen often. But when it happens on more and more with mechanical ventilation, we see a little more of this reversal of the dome of the diaphragm. It is not an of course finding. It's an extremely important finding. It is called for action. You drain that pneumothorax. If you do a CT scan on this patient, you'll find that the pneumothorax envelops the whole lung, and you don't see it because this is a supine flow. Also because the rest of the lung is completely white. So this is an important sign. When seen, is a call for action. Now, I told you that this is something that is not often seen. Pneumothorax on the supine form is not often seen. So we use what is called as Decubitus Views. In the vast experience of interacting with pediatricians, Decubitus means something big for them. They don't understand. I have not understood what is this Decubitus is common because you have not seen it being done. Yeah. So if you are a pediatric resident, you just see when a Decubitus view is done, it's simple. Now, if you can't see this like this, because it's a supine form, you do a view in which fluid levels are seen. It becomes like normal. What is the difference between a supine form and an upright form? There is gravity, right? Supine form eliminates gravity. That's the worst thing that can happen in chest radiology. So you want to make gravity work. And this is what we do. Now this patient is supine. And this is what is called a horizontal beam X-ray. This is what is done when you ask for a Decubitus view. This is one Decubitus view where the patient is supine. This is not a right lateral or a left lateral Decubitus view. This is a supine Decubitus view. The word supine Decubitus is really wrong, but we'll use it for the time being. What happens is that, imagine, this is like CT scan. The patient is supine and you have a horizontal beam. That's the opposite side is the X-ray bar. Saying if there are fluid levels, you will see fluid levels on the X-ray because this is a horizontal beam radiography. All Decubitus view for all practical purposes, instead of the X-ray coming from top down, is from side to side. So it's like doing an upright view. How does it look like? Now you can see what's happening here. This is how it looks like on supine view, and this is how it looks like on a Decubitus view. Look at that. Let's go back. Yeah, can you visualize this up and down? And this is up and down the same way. This is what is happening on a supine view. You suspect that something is wrong. There are signs here which will tell you that this is pneumoperitoneum, but here this is Akash syndrome. Even my ward boy can pick up that there is a pneumothorax, a pneumoperitoneum here. This is the advantage of taking a supine Decubitus view, but the lateral Decubitus view are somewhat different. So again, the important thing is that the cassette is here. The X-ray source is here, and the X-ray beam will travel horizontally. This would be a right lateral decubitus view because the patient is sleeping on the right side. What happens? If there is a hydropneumothorax, you'll see a fluid level like this. If there is a pneumothorax, you'll see air risen up like that. So if you're looking for pneumothorax on the left side, you do a right lateral decubitus view, the opposite decubitus view, because air rises. There is no remembering involved. This is simple. Therefore, so. Simple logic. So if you're looking for pneumothorax, you do the opposite decubitus view. On the other hand, if you are looking for pleural effusion, you do an ipsilateral decubitus view, for example, here. Pleural effusion here will collect on this side. And of course, we put some pillow there so that it's elevated. You do an ipsilateral decubitus view. Most of the time, you're looking for pneumothorax, so you do the opposite decubitus view. If you're looking for pneumoperitoneum, like the previous case, you either do a supine view or you do a left lateral decubitus view, because air will rise up to the right side. On the right side, there is liver, and it's easier to contrast air with the liver. Try to contrast air with the left lateral chest wall. So all of this is simple. Let me go through this once more. If you do a lateral decubitus view like this, air rises, fluid sinks. The rest of it is automatic. If you're looking for pneumoperitoneum, you will do a left lateral decubitus, so the air rises up against the liver, and you can see the pneumoperitoneum. Decubitus views are extremely useful for patients who cannot be moved. The ideal is to make the patient propped up. You don't have to have a patient 90 degrees. A little bit of propping up and you are now with gravity. It's like an upright view. If you cannot do that for some purpose, you turn the patient over and do the decubitus view and use the terms properly. Right lateral decubitus view means the right side is down and the left side is up, and the opposite with the left lateral decubitus view. I'm not going to repeat it. I'm sure you have made it out. When to ask for right lateral when there is fluid, when to ask for left lateral when there is fluid, and the opposite when you're looking for pneumothorax. It's simple. And you just have to figure it out in your mind after having seen this example. There's one more image, I think. Okay. This is the image when you have a left lateral decubitus view. The left side is down. The right side is up. So you can imagine that if there is a pneumothorax, it will collect here because the X-ray goes from front to back like this in a horizontal beam. If there's a pneumoperitoneum, it collects against the liver, and therefore it becomes easy to make out. I mean, I cannot tell you how useful these are. Rather than play around with more and more AP view, supine view, all that, or CT scan sometimes. It's quite wrong to do CT scans on these ICU patients, shift them down, do that when you just do a proper decubitus view to look for air in a hollow viscous. Okay. No, I don't want to take time. Okay, I got 5 minutes. Let me go through it. This is barotrauma. Now, this is something that you have to keep looking for. This is barotrauma in a child, and this is very interesting. I was a radiology resident when this mother came crying at 2 o'clock in the morning, or 3 o'clock or whatever, in the morning. I was sitting there, and the only complaint this mother was, my child's face is swollen. I don't recognize my child. This was a patient who was known to have bronchial asthma. They would usually come at 4 or 5 in the morning, have some aminophenol injection. That was being done. But this time she said, my child is completely changed. You touch the face, it's full of crepitations. So here what has happened is that with severe bronchial asthma, a few of the alveoli have ruptured. There is no pneumothorax, but it has ruptured into the mediastinum. And from the mediastinum, it has gone everywhere. It's gone into the axilla, it's gone into the neck. But the important thing here is that it has gone into the retroperitoneum. We can actually see the kidneys outlined by air here. So I'm showing this to illustrate how dissected air looks like. And in COVID times, we actually did a study with our adult medicine people, adult ICU care people, and the number of barotraumas and air all over the place is quite phenomenal. I think a paper has already been written up from Kokila Bed on that. So this is dissected air in the retroperitoneum, air in the lung, beyond the lung, in the pleura can do all sorts of things. It can go up to the thigh, dissect, like you saw in the, no, you didn't see in the scrotum, but scrotal air is very common when there is retroperitoneal air. So the important thing here is that when you don't see something here, or even if you see something here, don't miss these findings here. There's air here, and just looking below the domes of the diaphragm, rule number 25, RR rule number 25, I don't know where the others went, is, and looking below the diaphragm is an inherent part of looking at the chest wound. One thing I never miss is something below the dome of the diaphragm that's abnormal. Somehow that's there. I miss a lot of pneumothorax. I miss a lot of miliary shadows. That has become my registered trademark, missing pneumothorax. I mean, after 40 years of radiology, I still miss pneumothorax because I'm careless. And miliary tuberculosis because X-ray gets burnt out and I don't have the patience to change the window. I will assure you this much. If you are in a hurry to do anything in radiology, I suppose, or clinical medicine, you will miss finding. And I hurry because it's sort of habit with me to be hurrying. I mean, it's quite wrong. Somebody at my age to miss pneumothorax, but I do miss that off and on. Okay, so this is retropneumoperitoneum, air in the retroperitoneum that has dissected, and the mother was crying because the child was so swollen up that the face was completely distorted. I mean, we didn't have cell phone cameras at those days. I mean, that image is still in my mind of a crying mother and a swollen child with retroperitoneum, air like this. This is again pneumomediastinum. Post-operatively, you see the thymus. This is how the normal thymus looks like, what you see on CT scan. So this is innocuous. Most of the time, this is just a radiological findings of no significance. Rarely, pneumomediastinum can be so much that it obstructs venous return, especially of the superior vena cava. So this is dissected air. This is not air in the pleura because air in the pleura would have gone everywhere. And this outlines the thymus. And therefore, this is in the mediastinum. Yeah, now this is what I wanted to show you. So when you have a film like this, you can see behind the heart carefully. And this is a classical sign. You cannot miss this in your dream. You cannot miss it in your sleep. You cannot miss it at 2 a.m. in the morning. This is left lower lobe collapse. You see it well here. And if you have digital radiology, you change the window of the image, you will always see it behind the heart if you look for it. This is a simple finding. This is like a triangular wedge of collapsed left lower lobe. Depending upon how much it is collapsed, it can become more and more or less and less of a triangle. And that's something you cannot miss. You should not miss because it's often missed, because you are in a hurry, because you don't change windows, because the X-ray is not done properly. So you have to look for it in multiple ways. One way, of course, is to look at the view box, but this is a classic undergraduate sign of left lower lobe collapse, not to be ever missed. Because it's even behind the heart, people miss this and it should not be missed. That's why I'm spending a few seconds on this. Okay, this is miliary tuberculosis. This is straightforward. This is florid, confluent miliary tuberculosis, and it's very easy. But if you suspect miliary tuberculosis on the basis of clinical finding, the child has meningitis, spleen, spiking fever, and you don't see it on the chest wound, ask for a repeat chest wound. You may even do a CT scan, but that's not the standard of care. You don't have to do CT scans every time you have a clinical suspicion of miliary tuberculosis. You just have to see that the X-ray of the chest is done properly. Having said that, I know that CT scans get done still for miliary tuberculosis. That's a different ball game. And myself, I miss findings of miliary tuberculosis. So two things I missed pneumothorax and miliary tuberculosis because I missed it. That's it. And I'm aware of it. And now what I do with miliary tuberculosis If the X-ray is completely burned beyond repair, I ask for a repeat to look at soft tissues in miliary tuberculosis. Another example of miliary tuberculosis, this is more obvious. It's something that should not be missed. I mean, I know CT scans get done. As I said, that's not fair for the patients. It should be picked up. If you see CT scans with miliary tuberculosis, you go back to the plain film and you see it properly on the monitor. Every single time that child will have an abnormal chest film. It's just that we don't look for it carefully. And that is the whole thing about CT scan replacing plain film. And I think it's really bad medicine. Okay, sorry. What did I want to show? This one. So this one, I will give you 10 seconds for you to look at this carefully and see what you make of this. 10 seconds is a very long time. I stand in front of the microwave for my coffee to get heated up. 30 seconds is a real long time, and I started at 25. So I'm stopping it at 5 seconds. You have inversion of the right dome of the diaphragm. There is a dramatic difference in the height of the front and the back. And though this is not completely ulta like it should be, you would suspect that there is inversion of the dome of the diaphragm, especially if the saturations are not coming up. Then you would suspect it. The real way to make it out is on fluoroscopy, but this is something where you suspect that there may be inversion of the dome of the diaphragm. That was overt inversion of the dome of the diaphragm. So one diaphragm, other diaphragm at very different level is a finding that you should pick up every time, and something that is often missed or not even looked for because you are not even aware of that entry. Okay, this is my last slide. Okay. And this was a child with a long time from KEM, and we didn't even know what was going on. We thought this was consolidation, and not responding to any antibiotic. We didn't have CT scan those days. So our pediatric surgeons were trigger happy. They were brilliant people. They are pioneers in pediatric surgery in KEM, and they opened. And from the left lung, there was caseal material oozing. This was tuberculosis, adult tuberculosis in a child before the time HIV was not known. Why is this my last slide? This is my last slide because most times on chest radiology, common things present commonly. Like what I've said, you see it in a pattern. Once you know a pattern, you recognize the pattern and make a diagnosis. Occasionally, you see something like a zebra coming in. Four-legged animal turns out to be a zebra and not a dog. And that's again learning. It's not possible to make a diagnosis a priori before you see it. But next time you see something like this, you will suspect that maybe this is tuberculosis. That's an open mind. And that is wisdom. And wisdom is nothing but experience. I don't know how many of you study elephants. The matriarch of the elephant is the wisest of all the elephants. And that comes surely from living, experiencing. So, but you look, some of you will learn with time, but you should want to learn. And learning is why, happy, why, I'm done. Thank you.
Hello.
Yeah, hell.
I thought you might take one like half an hour more also if people are interested. I am okay with that.
No, it's okay. I mean, that would be a different topic. Anything more than 40 minutes gets boring. Yeah. So if you want something else, we'll have to arrange it differently. I have something to talk about tubes and lines. That's something important, but I don't want to do it now because it's 2 hours. 2 hours is cruel, completely cruel. If you're in a classroom and somebody talks for 2 hours, you'll throw rotten apples, rotten eggs, and rotten potatoes.
Okay, sir. Samir, sir.
And besides, yes. I will charge you extra if you want me to talk for 30 minutes.
Okay. That's still okay, sir. I will happy with that.
Okay.
The way I learned a lot of things today, like it's not like that I was not aware of, but then it was with the way you feel and see differently. How to look at the X-ray. Like I am so happy today to learn a lot of things new. X-rays are really a wonderful thing if you really take it seriously. It's not
They
like
are-
just to say do X-ray for CBC electrolytes and all the stuff as a routine part.
No,
X-ray
what,
definitely.
One
Yeah.
thing I would insist is that those of you who are teachers and have residents working with you, please
Yes.
buy them this book, Fundamentals of Chest Radiology by Benjamin Felsen. Keep a copy in your library and make sure that they read it before they pass. If they don't read it, don't sign their forms. It's compulsory reading. It's a beautiful book. And if they read that, they will learn 95% of all chest radiology. The best part of that book is it's fun. It's full of humor. It's great book.
Yeah.
Benjamin Felsen's Fundamentals of Chest Radiology.
So really excellent session, and just a simple thing as like a thymus, but we can miss, we can overdiagnose, we can have saying like pneumonia, or sometimes like to do CT scan for those. I have seen and I actually have done this, might be possible, or I might have heard. But now just a simple word saying that it is a fat and looks like a translucent or actually is yellow in color. Actually, frankly, I was not aware of that part. So unless you know some basic things, how to do and how to see, the mind see only that what we knows or what he knows. And really, we need to keep more such type of lectures. I'm sure, and I want Ravi Ramakant sir, you should take another lectures for us, maybe some different topics, and interesting people will still join. Unfortunately, we have only 100 people who comes on Zoom. So rest of the people actually come on the YouTube, and many actually complains me that you should increase the number of Zoom people. I say let's take about for the next time when it really happens.
Let's see. No, okay. You know what the bad thing about these Zoom meetings?
Yes, sir.
What is the bad thing?
People are not there actually.
Cannot
So
No,
interaction 1:1.
I have
Cannot
got a-
interact.
No,
Cannot interact.
I got used to it, and I don't usually entertain questions because they ask questions, I don't know the answer, and it's trouble. Anyway, the bad thing is that I don't get mementos.
We'll come to give
You
sir.
get the hint, so I'm looking forward to something in the courier. Okay.
Yes, sir. Yes, sir. Definitely.
Anyway, I'm just kidding. No. Anyway, shall we stop? Shall I go? We are done.
Anybody has any questions, or we can end of this session?
No,
Sneha, is you
anybody
there?
who has a question, please send it by email to me. Na? It's so
Yes, sir.
quite stupid to. I mean, I'm not comfortable answering questions on this.
Yeah, okay.
The lecture
Yeah.
hall is different.
Yes, sir.
And
Agree.
and remember the pale blue dot. Even faculty, even
I'm going to
senior
see
people.
that. Yes, yes, yes.
So please read that and write an essay on pale blue dot.
Sure,
Okay,
sir.
we are done. Thank you. Goodbye.
Thank you. Amol, you want to say something?
Yes, sir.
Yeah.
I will do vote of thanks now.
Yes.
Okay. Almost 500 viewers, 100 on Zoom and 400 on YouTube. So maximum attendance on YouTube was almost 400. A marathon session of almost 2 hours, more than 2 hours, I think, on pediatric chest X-ray. I owe my sincere gratitude to one and only Dr. Ravi Ramkantan sir for enlightening us with his great knowledge and also giving various tricks to crack difficult X-rays correctly. Sir is mentor to many stalwarts, a model of simplicity, and icon of genius, and still so loving. He is respected worldwide for his crystal clear concepts, which we all experienced in last 2 hours. Thank you, Ravi sir, from bottom of my heart on behalf of Maha AP. Thank you, sir. Thank you.
Thank you. Bye.
I also thank Chief Guest Dr. Jain Joshi sir, Chairperson of Maha Respiratory Chapter. I also thank Dr. Hemant Gangolia, President, Dr. Vinayak Patil, Vice President of Maha AP for their presence during today's session. I also thank Dr. Jay Bhandarkar sir for moderating this session. I also thank Dr. Samir Sadavarte sir on whose insistence and invitation to Ravi sir, who immediately agreed for today's session. I also thank Dr. Shekhar Kuber Shamrao for his presence in audience throughout the session and also for his patient hearing. I also thank Dr. Melkamu from Ethiopia for attending today's session. I thank all pediatricians, pediatric residents from various institutions across India for attending this session on Zoom and YouTube platform. We will again come next month with equally eminent faculties through Maha Subspeciality Connect. Thank you one and all. Over to you, Neha.
Thank you, Amol sir. We are all just mesmerized by Ravi sir's talk, and he has excellently brushed up pediatric chest X-ray. I would like to say that, sir, you are not only a good teacher and speaker, but an artist whom we all just want to listen and just listen. Thank you so much, sir. Friends, though chest X-ray is the commonest radiological investigation in pediatrics, but reading an X-ray is an art. Today, we all felt like we are back to our school days, and it was a great fun learning. And after this session, definitely we all are not going to say that X-ray is just black and white, but there are many shades of gray, shades of white. And X-ray film is not just a flat film, but it has depth in it. So friends, start learning, reading any X-ray, old or new. And as just sir said, that starts asking why. So by this note, I end this session. Thank you so much, sir. And thank you everyone for attending today's CME. Thank you.
Why to end the session?
Such an excellent session. Yes, that is true. But yes,